it is going to be a GLP-1 medication, you need to know why do you want it. If it is for losing 20 pounds or 10 pounds, I'm just going to use it for 2 months and I'm going to stop it, then that's not the reason why you should be taking it at all. These medications are not cosmetic weight loss tools. They are metabolic and cardiovascular interventions. They have true side effects. There's a risk of nausea, gastroparesis where your stomach just distends, pancreatitis, which can become a lifelong kind of a very overwhelming, debilitating long-term condition. There are multiple trials like the LEADER trial, the SUSTAIN trial. They talked about reduction in the major adverse cardiovascular events and strokes up to 20% reduction. That's a massive number. When you have this kind of outcome data on a drug, the drug is not a lifestyle medication. It is a disease-modifying therapy. And that's why cardiologists like me are paying attention to this medication.
Welcome back to Infinite Health with Dr. Arasi Maran. This show is about stepping away from the hype and looking at health decisions through a long-term evidence-based lens. Few topics in medicine have entered the public conversation as quickly or as emotionally as the GLP-1 medications. Depending on where you look, they're described as miracle drugs, shortcuts, or something everyone should already be using. So today, Dr. Maran isn't just taking a side. It's about slowing the conversation down and understanding how you think about GLP-1s clinically, who they're actually for, who they're not, and what responsible use really looks like when long-term health is the goal. So welcome to Infinite Health. It's so nice to see you, Dr. Maran. How are you doing today?
Doing good, Leila. How are you doing? And I'm so glad you chose this topic to discuss today. It's a very relevant, very hot topic right now.
Absolutely. It's definitely a hot topic. I feel like no matter where you go, what you're reading, what social media posts you're looking at, everyone is talking about GLP-1s in some capacity. And to my knowledge, there's so many different ones. So I'm excited to really dive into this because I'm curious. I know so many people are curious about it. So I'm interested to hear your take on it. So why do you think that GLP-1 medications have become such a focal point of longevity and health conversations so quickly? I feel like we heard about it and now we can't stop hearing about it. It seemed like it happened so fast.
Yeah, I think the speed of this conversation truly reflects a perfect storm. Dramatic visible weight loss results, number one, very aggressive social media amplification, number two, and celebrity endorsements, all colliding with a nation where over 70% of its adults are overweight or obese, according to the CDC 2023 results. But what has ignited the medical community's attention is not only the dramatic weight loss, but the phenomenal cardiovascular outcomes from liver disease standpoint, from kidney disease standpoint, from brain health standpoint. So there are multiple trials like the LEADER trial, the SUSTAIN trial, and more recently the SELECT trial, which demonstrated something way more remarkable than this cosmetic benefits of GLP-1, right? They talked about reduction in the major adverse cardiovascular events and strokes up to 20% reduction. That's a massive number. When you have this kind of outcome data on a drug, the drug is not a lifestyle medication. It is a disease modifying therapy. And that's why cardiologists like me are paying attention to this medication.
And so with that being said, I know there's so many assumptions and people have so many different opinions on GLP-1s, right? So what assumptions do you really hear patients making when they ask you about GLP-1s?
Yeah. So the thought process, they simplify it. Okay. Is it for me or not without understanding the appropriateness? And there's truly a complex matrix of cardiac risk, metabolic profile, comorbidities, long-term goals. There are multiple features to this. It's not a yes or no kind of a question. So the most frequent questions or the thought processes I hear is, oh, I just need to lose 20 pounds for the summer. This should be easy. Okay. That is missing the point entirely. These medications are not cosmetic weight loss tools. They are metabolic and cardiovascular interventions. But GLP-1 agonists are true medications. They have true side effects. There's a risk of nausea, gastroparesis, where your stomach just distends, pancreatitis, which can become a lifelong kind of a very overwhelming, debilitating long-term condition. There are thyroid conditions where you just cannot be taking it at all. So you really have to think about, why do you want it? If you remember our first episode, I say you need to know your why. So even if it is going to be a GLP-1 medication, you need to know, why do you want it? If it is for losing 20 pounds or 10 pounds, or I want to lose weight and get ready for this particular dress, I'm just going to use it for 2 months and I'm going to stop it, then that's not the reason why you should be taking it at all.
Absolutely. And at a physiological level, what problems were GLP-1s actually originally designed to address? Because, like you said, some people just want to take it to fit into the dress or lose 20 pounds, but that's definitely not the reason behind why these were designed. So, why were they actually originally designed?
Okay, so I'm going to get a little sciencey and nerdy, so just bear with me, okay? GLP-1 stands for glucagon-like peptide. It's an endogenous incretin hormone, meaning it's released from the gut after you eat and signals the pancreas to secrete insulin in a glucose-dependent fashion. Okay, that last part matters, because unless all your other diabetic drugs, where it decreases your blood sugar levels irrespective, this medication comes into play only when the blood sugars are elevated. So you don't have the risk of low blood sugars compared to the other medications like sulfonylureas, etc. Beyond glucose regulation, they suppress glucagon secretion. What does glucagon do? Insulin and glucagon are like opposing our hormones, and together they maintain our blood sugar levels. Okay. So insulin reduces the blood sugar level, and glucagon secretion, when you suppress that, hepatic glucose is not produced. It also slows the gastric emptying. What that means is, the breakfast you had is not out of your stomach in 2 hours, whereas it's sitting in your stomach for 6 to 8 hours. So since your stomach still has food, your hunger stimulation is not there. It creates a early satiety. Apart from that, it also acts on the hypothalamic appetite centers to reduce the sensation of hunger. And because you're not hungry, you don't eat, and therefore you get a caloric deficit. Finally, which is the part I love, it demonstrates direct anti-inflammatory and cardioprotective effects on the blood vessels of the heart and the heart muscle itself. So this drug, believe it or not, was approved for type 2 diabetes in 2005 in the name of Byetta. Okay. And these patients had a weight loss, which was considered as a beneficial side effect. No one made a big deal about it. But then the other versions, Byetta was exenatide. The newer versions, semaglutide and trizepatide, they are much more refined and, much more effective. And they have a much higher weight loss reduction. Up 20% of your body mass can be reduced with these medications. So yes, they cause a reduction in your weight, but they work in serious biologic manners, and the benefit extends beyond weight loss. And that's important to know.
And with patients, I'm curious because I know you mentioned there's the different names of them, like semaglutide and all these other ones. And I know I've heard like Ozempic, Mounjaro, all these names. When patients want a GLP-1, do you tend to choose a different one per patient? Like, are there some that are more beneficial for certain patients versus others?
So it all depends upon the side effect profile, right? So semaglutide, which is your Ozempic, etc., are the earlier generations. Trizepatide, the Mounjaro, is the next version of it, and the trizepatide also has a GIP inhibition, or the gastric inhibitory peptide inhibition. So it is like added on. Then you have ride, which is going to be G3. It inhibits the GLP-1, GIP, and also glucagon. So the red, which we will get probably by the end of this year or beginning of next year, helps in muscle mass preservation also. The bottom line with any of these drugs, which is why they're coming up with newer medications, is you lose your hunger sensation. You stop eating. and it also decreases your thirst sensation. You start drinking water, okay? And along with that, when we're choosing to eat, we are creatures of joy. We want dopamine hits. We end up eating ultra processed, high carby foods, okay? And not actual, we don't prioritize the protein intake. So we end up losing muscle mass. Okay. Well, so with the Ozempic or semaglutide or Mounjaro trizepatide, there's a lot more muscle mass loss compared to retatrutide, which will come in. And compared to semaglutide, trizepatide has less muscle mass. But in general, it's a big concern, loss of muscle, because muscle is our metabolic superpower. And if we lose our muscle, we will get into trouble, and you don't want skinny, fat people. Okay. So that's why it's really important to think about what your goals are.
I have heard that a lot about the skinny fat people. It's like people are losing all this weight, but since they're losing their muscle definition, it's still not the results that people want when they just want to lose weight and have, a slimmer body. And I've heard that a lot just like online. And I know, you know, it's so common that people are experiencing that. I've heard like Ozempic face and things like that. And because I not only along with muscle, I think like collagen's affected and all those sorts of things
Absolutely.
as well.
Yeah,
And
collagens are basically protein, amino acids, right? So if you're not eating enough protein, you're not getting enough amino acids for repair, and you're going to have a loss of collagen. The problem with this is we are focusing a number on the scale, or a number, the size on a dress or something like that. That's totally the wrong number to be focused on. We need to be focused on actual biologic markers, your body composition, your muscle mass, your body fat percentage. Those are the numbers we should be focused on.
and why does focusing solely on weight loss really miss the actual real clinical purpose of the medication?
So, because it's not an ideal marker, the whole concept of BMI was created as a insurance determinant, right? A metric for the insurance companies to categorize people. It has no health benefits itself. We should care clinically about what the weight represents. The weight actually represents a cardiometabolic risk, visceral adiposity, insulin resistance, systemic inflammation, atherogenic dyslipidemia, endothelial dysfunction. That's what we need to be focusing on. And the critical distinction is in the SELECT trial, right? The trial which showed that there's increased cardiovascular benefits. The cardiac benefit was independent of the weight loss. So that data suggests that these medications have direct cardioprotective mechanisms, anti-inflammatory effects, improvements in blood pressures, reductions in oxidative stress, which in turn makes the patients feel better. So just the number on the scale or the size of your dress, yeah, it's a marker, but it is not the marker. So let's say a patient loses 15 pounds on glutide and obsesses over the number on the scale, but the hemoglobin A1C or the insulin sensitivity goes on the other direction, the lipid panels goes in the other direction. We are not winning any games here because they haven't fixed the fundamental problem as to why they gained weight in the first place. They are looking for kind of shortcuts, and to use these medications as a shortcut is like, again, ostrich digging its face in the sand and thinking it's all covered. That's
Mhm.
how it is.
And how do GLP-1s actually intersect with metabolic health in ways that people don't even usually consider?
So, I don't want to kind of sound like a stuck record. It's the food we eat. Okay. We are what we eat. Like if you have a car which is fueled by gasoline, you need to put gasoline. You can't suddenly decide to put diesel and expect the car to function properly. Unfortunately, we are meant to be using aviation fluid as our fuel, but we are using, adulterated, lowest of the lowest, completely messed up diesel as fuel because we wanted instant energy. We just want to go, it's cheaper, it's readily available, etc. So the GLP-1, the food we eat the ultra processed, extremely with absolutely minimal nutritive value, hyper palatable foods, which we have kind of become addicted to, affects the liver, kidneys, heart, brain, neurobiology in every possible way. We have more obese people, more people with non-alcoholic liver disease, more people with kidney failure, and more people with depression, ADHD, different kinds of mental illnesses. Okay. So these are the metabolic problems which we are living with. GLP-1 comes into place. Okay. It makes you eat less. Okay. Even though it makes you eat less and it makes you eat less of the bad food, you could still be eating the bad food, but you're eating less of the bad food. Even that reduction has shown that liver function gets better. The fibrosis or the scarring in the liver function gets better. The Essence trial, which came out in 2024, discussed that. Your kidney function gets better. Blood pressure drops, and the blood pressure drops, the kidneys get better. The heart failure, we all have as we grow old, our heart muscles get stiff and you get heart failure with preserved ejection fraction. That gets better. And there is emerging data that it's great for Parkinson's disease and Alzheimer's. And our addiction mentality gets better. People stop gambling, shopping addiction got better, and alcoholism is getting better. So it is truly a metabolic platform. It's not a single target drug. So therefore, since it's not a weight loss drug, the implications of it is much more broad.
And I have heard that, for example, people are drinking less and gambling less, and it has such an effect on that as well. And I know you touched on earlier, some people are the right candidates for a GLP-1 and some people are not. So when you're deciding whether a patient is a good candidate, what factors really matter the most to you?
Well, okay, let's talk about the people who should not be getting GLP-1s, okay? An absolutely low risk patient, no family history of heart attack, stroke, diabetes, high blood pressure, with just like an extra 10 pounds or 20 pounds of weight loss. I don't think that patient needs to be on a GLP-1, okay? If you have had or family history of thyroid cancer or have had personally a thyroid cancer, especially medullary endocrine neoplasms, they call them MEN syndrome tumors, you're not a candidate for that. If you've had a history of pancreatitis, you need to talk to your doctor about why you got pancreatitis and then decide whether you're a candidate or not. If you have severe diabetes and your stomach emptying is already messed up because of your severe diabetes, GLP-1s will make it worse and you are going to end up with, a stomach distend or aspiration pneumonia or something like that. If you are planning to get pregnant and you want to lose weight just before you get pregnant, it may not be the right medication for you. Okay. And if you have eating disorders like, anorexia, bulimia, etc., it is a very tough medication and you should not be on it. So I would strongly, have this conversation with your provider. And again, your internal audit, be your own Sherlock Holmes, and then go from there. So who are the patients who I readily prescribe GLP-1s to? If you have established atherosclerotic cardiac disease, previous stroke, previous MI, blockages of the blood vessels of your legs, it's a class 1 ACC-AHA indication. Okay. If you have type 2 diabetes and you are at a very high risk of heart attacks, even without, I haven't done a heart cath, but, I know your diabetes, you've got long-standing diabetes, then you are a great candidate for that. If you have heart failure with preserved ejection fraction and you are also obese, then you're a fantastic candidate. And patients with diabetic kidney disease, etc. If you have obesity and obesity plus high blood pressure, obesity plus sleep apnea, obesity plus lipid abnormalities, obesity plus liver dysfunction, then you are completely a phenomenal candidate for semaglutide.
And you touched on something earlier too about not taking it before getting pregnant. But I also heard that people are getting pregnant now that had fertility issues before this from taking GLP-1s.
Sure. So, if your goal is to, I want to get help, you're struggling with infertility because of polycystic ovarian syndrome, which is a component of insulin resistance itself, then getting on these GLP-1 medications and resetting your metabolism is going to be fantastic. But there is a rebound phenomenon, okay? Like every medication. If I have high blood pressure and I take 4 medications for high blood pressure, okay, if I stop all 4 medications, in a matter of time, my blood pressure will get high. And in fact, it might rebound to the other end, and I might end up in the emergency room with a hypertensive emergency or urgency. Okay. If I have cancer and I'm on a chronic suppression medication, and if I stop the medication for cancer, right? So, the same way, obesity is a chronic disease. And you're taking this medication to help you manage that chronic disease. In pregnant women, it's a very tricky situation. They may be infertile. You give them the GLP-1, their fertility rates improve. Then they get pregnant. You obviously have to stop them because we do not have pregnancy-related studies with these medications. So you're going to stop them. Now your hormones are going haywire, and then this crutch which you were depending on is suddenly taken away from you. So it can be very difficult. So if you are using it for fertility purposes, you need to be working on more than just the GLP-1. You better be weightlifting, you better be exercising, you better have a health coach, you better have a team working with you to help you when you're not on this medication and you're pregnant.
And, speaking about these concerns, what risks concern you the most when these medications are used without a long term plan or without, like you said, a team?
Absolutely. I think my biggest fear is the lean mass loss, the muscle loss, right? I was on inpatient service just the past week, and I was obviously taking care of very sick people. And most of them, the 60s and the 70s and the 80-year-olds, they were just skin and bones. There was no muscle in them at all. And as I was doing my teaching rounds, I was like, this is just age-related sarcopenia. That is, we all tend to lose muscle mass as we grow old. Now you add this component of GLP-1 and reduce your caloric intake overall without any of, the strength training or resistance training, we are compounding this skinny fat problem. And then we're going to end up with people who are sicker, but they're just thinner right now. So the GLP-1 induced weight loss, it's not just adipose tissue. 25 to 40% of the weight you lose can be muscle mass. So you have to prioritize your protein. You need to go and do some sort of resistance training or strength training, because otherwise you're going to have functional muscle, which is an independent predictor of how long you live, how well you live. And if you lose that, I think that's a big, serious concern, which is not being addressed properly. And I feel we're not loud enough about that. Along with the GLP-1 prescription, here's the personal trainer, here's a gym membership. They should give a discounted gym membership or some sort of education about that has to be there.
Absolutely. It has to work hand in hand. And I know some people are just being able to get GLP-1s without, like you said, having a team, without having all these plans set in place to make sure that they're maintaining their muscle, to make sure they're working out and make sure they're eating the right amount of protein. And there isn't enough knowledge about this, the way that some people can access the medications. But it's also, these medications are not supposed to be taken forever, right? So how do you help patients think about what happens after the medication stops?
So, it's very interesting. So you truly believe these medications should not be taken forever. Why do you say that? What makes you say that, Leila?
I don't know. I think that was my understanding. It's not a lifelong medication, or is it something that people take forever? I know I've just heard that people will take the medication and then they stop. And if they weren't doing the things properly, they can.
And it's going to rebound. I mean, it's again, you would never tell someone who has breast cancer and is on chronic suppressive therapy to stop their medication because it's too expensive or anything of that sort. Why are we treating obesity different from cancer? If you have asthma, if you stop your inhalers, you will get your asthma back. There is apart from an acute bacterial infection where you can take a medication for 1 week, 10 days, 2 weeks, We only have chronic diseases in our, that's what we have. So if you want to completely normalize, man, it can be done. I'm not saying you, I mean, and please don't, I'm not endorsed by any of these companies, and I'm not trying to sell this medication for the rest of your life here. But if you want to come off these medication, then you are going to be on a mission to figure out why you gained weight in the first place. Okay. And have this action plan A, plan B, plan C as how you're going to mitigate yourself when you are put in the same situation of increased stress or financial difficulties or whatever emotional trauma which led you towards this such behavior. And sometimes, and some patients, the noise of food is naturally too high. It's almost like it's a disease, how a schizophrenic patient has voices in their head, which is quietened by their antipsychotic medications. That's what GLP-1 does too. It reduces the food noise. I love my chocolate. Okay, I've talked about this. And I started my personal weight loss journey 10 years ago when I turned 40. Okay. And at that time, the ketogenic diet was the big rave, and it made scientific sense to me. So I jumped on it. And that was the first time in my life the noise of sugar went away in my head. But that took a lot of effort. And so sometimes that with it becomes too much. So the reason why we are talking about thinking about stopping these medications is because of the cost of these medications, because these companies have put such a high price on them. If these medications are, as the patent is going away, if these medications are cheap and are readily available, and you're taking it for the right reason, and you're not using this as a cosmetic Botox kind of a thing, then, managing yourself is important. You can come up to the least dose needed, which is what the microdosing, it's a phenomena they talk about. You don't need to take the full dose every week. Instead, you take a fraction of a dose every other week or something like that, so that you get the metabolic benefits and you don't need that much of appetite suppression like what you needed in the beginning of your journey. So that can happen. But again, trying to navigate this all by yourself is just, it's too much. It's ridiculous.
And even speaking about that, about maybe microdosing and taking the small dose over, a long period of time. But what does responsible GLP-1 use look like when longevity, not just short-term results, is the goal?
Okay, fine. Love it. Okay. So the medication is doing all the hard work. Okay. It's kind of suppressing your neurobiological hunger. It improves your insulin sensitivity. Fine. So the food noise is gone. Okay. Now, this is a perfect opportunity for the individual to kind of work on themselves. Okay. The internal audit. Why do I like to eat my popcorn? Why do I like to eat my chocolate? Why do I like the extra glass of wine? Why am I going for a second or third helping? Okay. So doing that mental work, the mental work is the key. Without the mental work, none of this can work at all. That's the ultimate key for success without the GLP-1 too. The next is progressive dietary protein intake increase so that you protect your lean mass. I mean, it has to be there. And resistance training, at least 3 days a week, not just slow walks. You are actually lifting weights. You are using resistance bands. You're doing more than just walk. Okay. Sleep optimization and stress management. You can do all the GLP-1s and everything, and you sleep for 4 hours per day and not get adequate sleep. You're not just hyped up the whole day. You will end up with heart disease. You will end up with the stroke. All of that will happen. You might be skinny doing that, but you'll still get all of that. Okay. And you need to monitor yourself, metabolic monitoring every quarter, every 6 months, depending on which phase of initiation you are. So this is truly a bridge to a durable lifestyle change, and the medication can be eventually tapered. Okay. For some people, for the obesogenic individuals, that is individuals who are genetically predisposed to getting obese, that is, I eat a donut, you eat a donut, I gain 5 pounds, nothing happens to you. I'm an obesogenic individual. So for someone like me, then I might need a smaller dose or
Mhm.
an altered therapy. So we don't know, there are things we still do or don't know. That is, if I stop the medication, do I still have the 20-year cardiovascular outcomes or the improvement in my liver, kidney functions, etc.? Are those durable also? We don't know that yet. So we have to wait and see how that evolves.
It's so interesting because they're so commonly talked about and they're so, so many people are using these. But like you said, there's really not that much research in certain aspects yet because it is so new. It just happened. It seems like it happened and kind of took over so quickly. And I know everyone probably questions like, should I take this or should I not take this? So for someone listening and wondering if this is right for them, what's the wrong question to be asking?
What's the wrong question to be asking? The wrong question to be asking is if you are looking at it as, I just have a weight problem. Okay, your weight is not a problem. Your weight is a visible expression of an underlying metabolic story,
Oh.
often written over decades by your genetics, by your current lifestyle of sleep deprivation, stress, processed food environments, hormonal disruption. A GLP-1 can help edit parts of the story. It's not going to rewrite it. So the wrong questions are, how quickly can I get this medication? How quickly will it fix my weight problem? Those are wrong questions. The right questions are, is this medication actually going to make my heart health, my metabolic risk? Is it going to reduce my metabolic risk? And how does this medication help my overall long-term goals? If you are in your 40s, 50s, 60s, your long-term goal is a healthy 80s, 90s, 100s. Whether we like it or not, if we do things right, we may live to see 100 years. And in that 99th year or your 95th year, you want to be up and about walking, you want to be having a conversation, you want to have cognitive impairment. That's our goal. That
Mhm.
needs to be your trajectory. The next to ask yourself, are you ready to build a lifestyle infrastructure to make this medication meaningful and the effects of this medication durable? You have to ask that question with yourself, looking at yourself in the mirror. Then,
Mhm.
do you have a good clinician who will work with you, who will monitor you longitudinally, not just prescribe this medication and disappear? Which
Mhm.
is what is happening now. You go to a compounding pharmacy, you get this medication, and that's all. You don't know what else to do with that. So, yeah.
Yeah, absolutely. And I know people are just getting it online and like we said, like maybe not doing the right things to maintain it and just taking it without knowing the right steps. But it's also like medication decisions work best when they're grounded in context and not pressure. So I know GLP-1s aren't a miracle or a moral statement, but they're a medical tool and tools are only helpful when they're used thoughtfully. So with a clear understanding of risks and benefits and what comes next. The goal of conversations like this isn't to tell anyone what to do, right? It's to replace confusion with clarity and help people approach medical decisions with less fear and more confidence over the long term. So I think that this was so important to talk about. I know there's so much noise out there around it. So it's really great to hear it from an expert who really knows about the metabolic health aspect and not just, like you said, the aesthetic more so.
So, did I answer your question? Which side of the GLP-1 am I on, Leila?
I think you're pro if you do it the right way.
Yes, I am pro if you do it the right way for the right reasons, after you've asked the right questions, and truly asking the right questions, understanding the mechanism, and understanding the things it won't do for you. It's not going to keep you thin. It might make you thin, but it's not going to keep you healthy. So being thin and being healthy are two different things, and you need to fight for your health.
Absolutely. Fight for your health. I remember you saying that the first episode, and also be your own detective and give yourself your own audit. So I think if someone thinks they're maybe a candidate, I'm sure this was helpful for them to listen to. So as always, thank you so much, Dr. Maran, and I can't wait to talk to you on our next episode.
Thank you.